So a little bit about Boston. Boston is the largest city in Massachusetts. We have a population of approximately 600,000 people, and it doubles during the workday when people come into their businesses, they come to school.
Boston's an awesome place to live and work. It's a very diverse city. We have many historic sites. So from the infectious disease public health perspective, we could have anything arrive on our doorstep within 24 hours.
And Boston's a great city to both live in and work in. I mean, for me in particular, I've been a long-time resident here. I'm here over 30 years living in the city. And what I've really benefited from is an increased emphasis to really focus on the health and well-being of all Bostonians. People are using bicycling much more in the city and also walking much more.
And we are a city of neighborhoods with distinct populations and distinct infrastructure, all of which will be evaluated in terms of the signals.
The Boston Public Health Commission started to do syndromic surveillance a number of years ago in response to the bioterrorism threats that were happening across the United States. Initially, we were hoping to find early detection for events like anthrax exposures, but as we became more familiar with the system, it became apparent that this was a system that offered a cost-effective way to detect many things of concern to local health departments.
Some of the examples of ways we've used syndromic surveillance in Boston that I think really shed light on its importance has been, for example, around flu epidemics and looking at the burden of illness around flu. So we were very early on during the H1N1 epidemic able to not only be able to see increased utilization in our emergency rooms. That was due, in fact, to flu-like symptoms, people coming in with flu-like symptoms, but we were also able very quickly to look at that information and be able to tell, for example, that our Black and Latino residents were coming in reporting symptoms, serious symptoms related to flu-like illness at a much higher rate than our white residents of the city. And in fact, we could then look up and see which neighborhoods seem most affected by the flu epidemic and be able to target our resources.
Hi, Jen.
Take a second.
Sure.
Syndromic surveillance augments information that we get in other ways. So when we get an initial report in of an infection that concerns us, we can then use syndromic surveillance to help us find out if we have other cases.
It does sound like we should take a closer look at this. Why don't you gather the team together? We'll meet in the conference room. We are responsible for disease investigation, surveillance, prevention, and control of infectious diseases and communicable diseases within the city. It's a role that is ever-changing. It's unpredictable. You never know what's going to happen. So you come in and you think, oh, I'm going to be doing these cases today, and then you get the phone call.
So this morning I got a call from a physician over at the city hospital, and he's reporting that he's got a lot of little kids coming in with this unusual rash. About 11 cases right now, all under the age of 5. He's talking about blisters around the mouth, a rash on the tops of the hands, tops of the feet, some really unhappy little kids.
Anything in the media or any alerts that anybody has seen?
A few weeks ago there was an FE alert about Coxsackie A6 virus activity in the south.
Well, it'll be important that we get some laboratory confirmation. If this is Coxsackie A6, it's a different strain than we usually see, and I want us to have us prepared and ready to go. Maren, we're also going to need you to work on a blog.
For sure.
And Jen, I'm going to need you to look into BioSense and see if there's anything that's being reported with the sites that are sharing data around Coxsackie. And this is where the excitement is, this cross-collaboration, this pulling on other expertise that allows us to address many issues that are affecting the residents and the institutions in our city. All of this results in a healthier Boston. So, what have we learned? Pat, why don't you start?
7 samples were submitted, and all 7 came back for Coxsackie virus A6.
Okay, well, we've got a diagnosis.
So I did some graphs showing the trends from the past 3 years compared to what we're seeing this spring, and some really interesting results. In blue, you can see that it usually spikes in the summertime, but what we're seeing right there is that big spike, and that's not even all the data yet.
Looks like we're going to have to move forward with an alert.
It's drafted and ready to go.
We also want to engage with our schools, our daycares, our communities, our community-based organizations, our churches. All of these result in a healthier community, this broader communication. Because primary prevention doesn't occur at the healthcare sector, it's actually occurring in the community.
Syndromic surveillance has become an integral part of our overall surveillance for public health concerns in the city of Boston. Certainly in the infectious disease area where we first used it, it'll continue to play a key role. But as time goes on, we're using it more and more in areas such as injury prevention. And I believe that this will continue. Surveillance is moving in 2012 to be more and more data mining and electronic reporting. It's not a standalone system, but it certainly augments information that we get from other sources. And I think that it's the wave of the future.